In our Rudolph lecture this year in transplant surgery. Gonzalo Sapisochin is an associate professor of surgery at the University of Toronto, and he's the Greeley Chair in transplant oncology for the University Health Network, where he's an HPV surgeon oncologist and transplant surgeon. He's originally from Spain, where he received his medical degree in Madrid, and then went on to complete his residency in Barcelona at the Hospital Valdebrón, where his interest in the treatment of hepatocellular carcinoma started together with the group of UCLC. Then he moved to Toronto to complete his HPV and transplant fellowship. He was later recruited there, where he has a very busy practice in HPV and transplant. His research interests go along on the interface between transplant and cancer. He runs multiple trials on the treatment of HCC, cholangio, treatment of colorectal liver mets. And he was recently appointed the inaugural chair in transplant oncology, the Greeley Chair in transplant oncology. It's a great pleasure to have him here to speak about transplant oncology in 2024, past and future, and I'm looking forward to this lecture.
Thanks so much. Thanks so much. A real honor for me to be here today at UVA with all of you. And in the next 35 to 40 minutes, I'd like to, explain a little bit where the field has been, and especially, I think, more interesting where the field is and where we're going. These are my disclosures. And as Nico said, I do split my practice 50-50 on HPV surgical oncology and transplantation, and that has helped me, have a bit of a broader vision on how to develop transplant oncology, which I think is important. I thought I would give you, very briefly about my journey. Nico explained. So I was born and raised in Madrid. My parents are actually Argentinian, and I did med school in Madrid. While I was in Madrid, I was already very interested in hepatobiliary malignancies. So as a med student, I spent a couple of months in Memorial. Bloomgard was still there, and I remember looking at all the videos that Bloomgard had, etc. I moved to Barcelona to do my residency when I also I got my PhD in Barcelona. And I got a lot of interest in coming to the US, and I spent a month at the transplant program in Miami when Andres Sakis was doing like 50 or 80 multiviscerals a year. I spent some time at UCSF with John Roberts, Nancy Asher, and others. And I then moved to Toronto to do my fellowship. At the beginning of my practice as a faculty, I actually spent some time in Korea at the Assam Medical Center, which is a very large HPV and transplant program. And, Nico and I have been friends for a while. Nico was we were co-fellows for 6 months, and then he was my fellow. And, we've been good friends for a long time. So what is transplant oncology? We like to, describe transplant oncology with 4 main pillars. One is, very clear, and it's what mainly we're going to talk about today, which is the multidisciplinary cancer care, including organ transplant, which is basically utilized transplantation as a matter of treating hepatobiliary cancers. There's a very surgical, but I think very interesting topic, which is extending the traditional margins of surgical oncology with transplant techniques. And, when we are able to combine some of these techniques, we can do ex vivo resections, we can do vascular resections in hepatobiliary malignancies. And I think there's a lot of, more research we could do in that phase instead of just doing cases. And then there's 2 more basic science concepts. One is, where the field of oncology is really moving into immunotherapy. What do we do with immunotherapy, immunosuppression, really a black box there. And the other thing that I think is interesting for scientists is that, a liver that we're explanting with an example, 20 liver metastases, is an amazing source of genomic material to do a lot of very interesting science. And oncologists get very excited when we tell them, well, we can explant the liver with 4 HCCs, some treated, some not treated. We could analyze the different things. So I think that's a great field to explore, especially for the young faculty in the room. And this is not new. Some of you may have heard about, and I hope most of you, about Thomas Starzl, who started transplant. And as you can see, the first 6 to 7 transplants that Starzl did at the time in Denver, they were mainly transplant oncology. Things didn't go well, and as you can see, the survival of these transplants, these patients didn't die of cancer recurrence. They died for, other reasons. And basically, that was mainly stopped for many years. And then, transplants, the indications were different afterwards. And things have really changed. And why are we in a new era of transplant oncology? Well, I think perioperative mortality for transplant now is pretty low, so most patients do pretty well. We've really increased organ availability, and I think we are in the middle of a huge revolution with machine perfusion, etc. So we have more organs. I think we've really learned how to minimize immunosuppression in cancer patients, and we're less worried about rejection, and we're able to, modify things. I think, the world of systemic therapies for hepatobiliary malignancies, for colon cancer changed a lot in the last 15 years, but now we're again in a huge revolution for HCC and cholangiocarcinoma. We'll talk about that. And then, treatments for Hep C have really changed our waiting list, and the patients with transplant were not transplanted decompensated Hep C patients anymore. And many, jurisdictions, they don't see any of these patients. And, I come from Spain, and obviously this is not a reality in North America, but in Spain, they basically don't have a waitlist mortality. Patients get listed, and a week later, they get an organ offer. And there's, I was in Boston yesterday, and I learned that in Beth Israel, they have a 14-day waiting time. So I think this is starting to come, more organs, more organ shifts, and, there's going to be really a decline in the waitlist mortality. I thought I'd start talking about some of the, principles of transplant oncology and controversies. So again, liver transplant contributes to really, extend the conventional margins of surgical oncology. Basically, it's the, largest margin R0 resection you can do for an hepatobiliary malignancy. Obviously, this is not for everyone, and you're not going to be doing transplants in patients that have metastatic disease. So this has to be patients that have exclusive liver-restricted disease in most cases. Neoadjuvant is the way to go. You're going to have to see some response to these tumors. You're not going to jump into a transplant directly. And then, as I said, this is not for every patient. There has to be some minimal inclusion and exclusion criteria that need to be, determined a priori and to have clear, achievable endpoints. I think the other thing that's important is that when we talk with oncologists, the oncologists need to understand that there's never going to be, pharma trials in transplant oncology with 600 patients per arm, $30 million trials where we're going to be able to achieve, the outcomes that sometimes they are trying to make us find. And I think we need to find other ways, smaller trials, to convince the oncology community that this is, worth to do and worth for patients. And finally, very important, this is a team sport, transplant oncologists, HPV surgeons, surgical oncologists, hepatologists, et cetera. This is a big group of people that manages these patients, which are complex. So now I'm going to talk about different, hepatobiliary malignancies where transplant is an option, and I'll start with the, bulk and the biggest population, which is hepatocellular carcinoma. So transplant represents the best treatment option for hepatocellular carcinoma in terms of long-term survival, and the reason is because, again, we're treating the cancer with the widest margin, but more importantly, we're treating, Paul Gregg used to be my mentor, one of the hepatobiliary surgeons in Toronto. He used to say, tell patients, well, we're leaving behind the field where these tumors grow. So if you're resecting the cirrhotic liver, the chance of recurrence is obviously lower. We don't transplant every patient with HCC, but certainly will achieve the best outcomes. And there's many programs, including ours, where already 30 to 40, and in some cases 50 to 60 patients that are currently being transplanted are already transplanted for transplant oncology indications, in this case, hepatocellular carcinoma. And I always like to think about different intra-abdominal malignancies, which are obviously completely different. Pancreas cancer, cholangiocarcinoma, gastric cancer, with new indications, with new neoadjuvant therapies, et cetera. If we think about many of these malignancies, the outcome, the 5-year survival of these patients with neoadjuvant, sometimes with adjuvant, if you look at all comers, is probably in the 20 to 30% range. HCC patients with multifocal HCC with a transplant, we can achieve 5-year survivals of 70 to 80%. So as a treatment for cancer, it's a very good treatment. And now, and this is unpublished, hopefully we'll publish this very soon, we're starting to see, this is SRTR data, patients within Milan criteria, we're starting to see median survivals of over 10 years. Again, median survivals. So we're talking about, immunotherapy drugs that give median survivals of 24 months, median survivors of 12 years with a liver transplant. So I think it's clear that patients that have tumors within the Milan criteria, and otherwise obviously are good candidates for transplant, they don't have extrahepatic disease, they don't have vascular invasion, I think we need to be very adamant that these patients need to be, referred to a transplant program, at least for assessment. The 5-year survival, as I said, is excellent. The recurrence rate is very low, and the median overall survival is very good. So from a patient perspective, this is what patients need to be offered if they are candidate for transplant otherwise. Now, this is Vincenzo Mazzaferro, who has become, again, a little bit of a mentor in the distance, but Vincenzo Mazzaferro was the person, designing the Milan criteria, so small tumor, single, HCC less than 5 centimeter or 3 less than 3, and it's great outcomes, we just saw that. However, this is probably too restrictive. It's going to deny transplant for patients that are actually going to do pretty well if they have a 5.1 centimeter tumor. And when we think about not transplanting those patients, we need to think about what's the alternative. Okay, I don't give a transplant to a 5.3 centimeter tumor. I can't resect that patient. Then the alternative is stays with a median survival of probably 24 to 36 months. So we need to think always about what's the alternative for our patients. So then we start to think, and I think the community is starting to think, like, size and number seems pretty simplistic. Are we really just selecting patients with just size and number? And there's ways we can expand transplant criteria for HCC. One is just to, create more expanded criteria with just size and number. But I think we're starting to think, and we use this in many other malignancies, about neoadjuvant therapies, downstaging, response to therapy, which is going to be probably a better answer on how to select patients. Here, there's other things. We need to think about what is tumor response, how do we measure tumor response, is tumor response a surrogate of tumor biology, and obviously what we talked about, which is going to be important, is organ availability, and I'll kind of touch about that a little bit at the end of my talk. And obviously with this framework, what are the limits of liver transplantation for hepatocellular carcinoma? So selection criteria really, many programs around the world, and this gets very messy, everyone wants their name there, has developed a different selection criteria. Is it, 6.5 centimeter the limit? Is the limit total tumor volume? Is the limit? There's many criteria, and I'm not going to go through this. I just wanted to let you know that, more and more we're going outside of just tumor number and size, which again, for everyone doing surgical oncology seems very simplistic, to adding some, biomarker response, some biological response, some surrogate that's going to give us more information than size and number. And in Toronto, many years ago, we decided that size and number was not the answer. So we developed the extended Toronto criteria where we don't have a limitation in size and number, but patients can have, constitutional symptoms. They need to be ECOG 0. They can't have cancer-related symptoms. And we do a biopsy of the largest tumor to make sure they're not poorly differentiated. Again, this is not perfect at all, but at least we started to include some, biomarkers or some ideas of which patients may do better or not. And with this in mind, we published our data in 2016. If you look at intention to treat, so intention to treat is from the time of listing, from the time you list the patients. Patients in the beyond Milan group are going to do worse. They're going to drop out more, so they progress while they're waiting. However, when you look at post-transplant outcomes, again, this is probably a type 2 error. If we had 1,000 patients, this would be significant. The outcomes are worse than Milan, no question. But remember, patients beyond Milan had a 5 and 10-year outcome of 68% and 50%. And again, thinking back about what would have been the alternative for these patients, and definitely wouldn't be that survival. And actually, Mazzaferro has already kind of moved away from size and number only. They developed this metro ticket calculator where they include the sum of size and number, but then they include a biomarker, which has a lot of limitations, but it's the only one that's really validated, which is alpha-fetoprotein. And if you go into their calculator, you can look at a patient that has tumors clearly beyond Milan criteria. So 4 tumors, size 4.8, AFP of 5, the predicted 5-year outcome 83%. And a patient that's clearly within Milan criteria, so 3 small tumors, all of them less than 2 centimeters, and AFP of 700, outcome 67%. So the answer is not size and number. The answer has to be others, and it's not going to be only AFP. So with this in mind, many have developed, protocols for downstaging, and I know you guys use a lot of downstaging here. This was mainly developed by the group at UCSF. So then we have, larger tumors that we try and treat and bring them down to Milan criteria, and with this, we know that the outcomes are similar. So I think we do have quite a robust data now that downstaging from UNOS, UNOS UCSF criteria, which is the upper limit where you're going to try to downstage to Milan, your outcomes can be similar to Milan. So response to therapy works, and we can expand, our criteria that way. This is probably the best, I said at the beginning that we can do large trials, but I think we need to encourage that we need to do trials. And this is actually a good example. This is actually a randomized controlled trial. It's probably the only randomized controlled trial in this field. This was published in Lancet Oncology 2020. And it was a randomized trial where patients were beyond their transplant criteria. Then they were treated with local regional therapies, TACE, TARE. They even included some TKIs in the mix. And then once they had been downstage to Milan, they randomized them to either getting a transplant or not getting a transplant. And I think it's important to see that, sorry, I want to go one back. Hazard ratio 0.2, hazard ratio 0.32. I don't know if there's any oncologists in the room, but imagine if there was a drug that was like this. This is what we're seeing with MSI high tumors in colon cancer. is amazing. I think oncologists make this joke that you can put a truck between these curves, right? These are amazing curves. This would be approved by FDA, the next day. So again, I think now we know that patients that are beyond Milan and get downstage are going to do way better if they get a transplant than if they don't. We've also looked quite a bit into, dynamics of AFP, and this is some study we published in JAMA Surgery some years ago. And I think what this shows is that even if you have a very high AFP, if you're able to control it with some therapy, and again, mainly local regional, but we're going to talk about how we're going to incorporate systemic therapy in this field, you can actually have good outcomes, even if your AFP is very high, and you can downstage it, compared to those patients that you're never able to control your AFP. So I think we do know, again, that AFP is currently the only biomarker, not perfect, but it's the only biomarker we have in the field of transplant for HCC. So again, thinking about this framework, what about response to therapy and not necessarily downstaging? So you have, again, tumors with no limitation of size and number. Obviously, we're talking about patients, as I said at the beginning, no extrahepatic disease. You treat them with local regional or systemic, and we'll talk about that. And then you have some sort of biomarker. As I said, right now, you basically have AFP, and then you have a way of measuring response, which is tricky, radiology. And I really think that assessment of tumor biology should be key in selection. I think response to therapy, and not necessarily go back to Milan, which is again size and number. You just need some response. You may have a patient that you never downstage down to Milan, but is responding very well. And again, I think there's a lot of therapies and lots of biomarkers in the horizon. That's a bit of wishful thinking that we'll talk about, but we're not there yet to utilize it. And even more controversial is the field patients that have portal vein tumor thrombus. So portal vein tumor thrombus has always been, and I think it currently still is, a formal contraindication for transplantation. However, we're learning that not every portal vein tumor thrombus is the same. This patient has a VP1, very peripheral thrombus, and this patient has SMB, main portal vein thrombus. This, can't be the same. And I think we're starting to learn, and this is the best, probably, paper we have, lots of limitations. This is a meta-analysis published in Journal of Hepatology last year, very heterogeneous data. However, we can see that if you look at all patients with portal vein tumor thrombus that got a transplant, the 5-year survival is 49%. If they go downstage, and again, we're going to small numbers, the 5-year outcome is actually pretty good. And what this tells us, or at least tells me, is that we need to do studies in this field and do prospective trials to try and analyze this better. This is, just generating us some thought of where the field can be going. And why is that? Well, because as I said, the treatment of HCC is in complete revolution, right? Like 10 years ago, we had sorafenib, it increased 3-month survival. It was a horrible drug. It didn't do much. And for many years, we've had nothing. So in the last 5 years, there's been 2 and now 3 trials, published in New England, positive trials comparing, combinations of immunotherapy and BEV with sorafenib head-to-head, and combinations of immunotherapy. So this is tremelimumab plus durvalumab compared head-to-head to sorafenib, positive trials, and now this has become the standard of care treatment for advanced hepatocellular carcinoma. So we just put this figure together that we're going to be publishing very soon, but I think it's very interesting if you look at, how things have evolved from a systemic therapy. Again, this is the, our dark ages of sorafenib, and now how, now we have a lot of stuff. And again, how we've evolved in terms of, size and numbers, different criteria, and now, including immunotherapy in the field of transplant that we'll talk about. And why is this? Well, I thought I'd show you this case, and I'm sure, you have may seen cases similar, or if not, you're going to see it. 22-year-old, no fibrolamellar, clear HCC, no evidence of liver disease. I think clearly unresectable hepatocellular carcinoma, very high FT. What do we do? So this patient actually got transarterial rate embolization, 6 cycles of atezolizumab, bevacizumab, according to IMbrave 150 trial, and had actually an almost complete response of the tumor. AFP went radically down. We're able to do a left lobe from his mom with cable resection. And I think this is something we would have never thought about in the past, and now we're starting to think that this may be an option for some patients. The other thing is that, also we're starting to think that, well, now we have great drugs for advanced stage. What about intermediate stage? What about patients that get TACE or get TARE? Well, we're again learning a lot. Like we're getting better results with ablative therapies like, microwave, SBRT, et cetera. We're getting better outcomes with TACE. We're getting a lot of experience with TARE. And now there's trials that are positive with combinations. So Emerald 1 was a trial combining the stride with the tremidurval with TACE. Lipo 12 was just presented at ESMO 4 days ago, positive not for overall survival, but positive for disease, for progression-free survival, which I think it's important because what's going to give us the survival in these patients is the transplant. What we need is to keep those patients in the waiting list or downstaging. That's why actually PFS is important for us. It's a very important outcome, and we can extrapolate some of this data for our patients. So there's always been a lot of fear, or I think there's still a lot of fear utilizing immunotherapy in the transplant list and what's going to happen with rejection post-transplant. This is a kind of non-official review. This is a paper that we're going to be publishing very soon. There's been 152 patients at least published in the literature, treated with a lot of different combination of different immunotherapies, combinations, etc. Rejection rate 28%, mortality related to rejection 6%. So I think the fear that we had that all these patients are going to get immunotherapy, they're going to do poorly, is not true. I think we need to know, need a lot of more information. Which are these patients? When do we stop the IO? I think we now have quite a bit of information that the immunotherapy needs to be stopped at least 4 weeks before the transplant. But if you have that washout period, I think rejection is relatively, within ranges that are acceptable. I recommend, if you're interested, this paper was presented like 10 days ago. This is a multi-center US study with probably the largest cohort. And again, the rejection rate in this patient, they had 7 rejections out of 43. So I think very acceptable outcomes. There's a lot of trials going on immunotherapy pre-transplant, a couple in the US. I'll show you our own trial that we're doing combined with Methodist in Houston. But again, just to know that this is happening and there's a lot of trials going on. As I said, we have our own trial where we're combining atezolizumab, bevacizumab plus local regional, so TARE or TACE, and accruing for this trial. And again, to get some answers, being the primary outcome, not only feasibility, but more rejection as a primary outcome post-transplant. So the next question becomes, well, if we're going to use immunotherapy, when do we use it? How do we use it? And this is a bit of a framework that usually I think where we're going to use it more is in patients that we're trying to downstage. We start treating them with local regional, and we can't get to enough downstaging, and then we can add immunotherapy. Patients that are actually within transplant and you're bridging or you're just waiting, probably more controversial. But if you have very long waiting times, this may be necessary for some patients. This is still developing. I think the other thing that's very interesting in this field, as in many other cancers, is going to be liquid biopsy. And this was a nice review published this year, mainly looking at MRD in resectable patients. If you think about the transplant population, and again, this is complete wishful thinking at this point, but I think maybe is the way we're going to do things. No limitation in size and number. You have a positive ctDNA. You treat with whatever treatments you can, and you wait until this is negative to actually offer transplant to these patients. Again, just food for thought for the future. So I'm going to move, to talk about perihilar cholangiocarcinoma, which obviously is a very different cancer, and I'll try and make perihilar brief, and then we'll talk about intrahepatic. But we've learned over the years that, some patients with perihilar cholangiocarcinoma are unresectable, which is the treatment of choice. You would never transplant a patient up front. You would offer them resection, but some you can't resect. And, the Mayo protocol developed this protocol, which is very similar to ours in Toronto, where patients that have a malignant appearance stricture, and they either have, positive cytology that we're very adamant of getting, or they have a high C99 without cholangitis. They have a tumor that's less than 3 centimeters from radial diameter, no extrahepatic disease. The tumor has to be located above the cystic duct, because if not, we're starting to get into Whipple territory. And they have to be unresectable. And again, unresectable, is a very subjective term. So what's resectable for me may not really be resectable for others, or the other way around. But the tumors have to be unresectable. And I think where this makes more sense is actually in patients with primary sclerosing cholangitis. Anyway, the protocol was developed. These patients undergo very aggressive neoadjuvant chemoradiation. So again, radiation, then they get chemo and brachy. In Mayo, we don't do brachy. At the time they were giving capecitabine, we've changed completely the protocol to give them standard of care. So now we would give them gemcitabine, cisplatin, and durvalumab. Patients get an expiratory laparotomy, and then if they don't have extrahepatic disease, they get a transplant. And the Mayo Clinic, has developed a very nice protocol. This is intention to treat. So this is from the start of chemoradiation. As you can see, PSC patients have a way better outcome than those that have de novo cholangiocarcinoma. Very good survivals in terms of intention to treat from the time of chemoradiation. When you look at the post-transplant outcomes, I would argue, 67% for a patient with cholangiocarcinoma is a very good outcome. De novo tumors do worse, and the risk of recurrence is here. Again, think about, as I said at the beginning, what's the alternative for some of these patients. In Toronto, we haven't been doing as well as the Mayo Clinic. We included 32 patients in a very long period of time. And our main problem is dropout. When you put these patients into one of these chemoradiation protocols, the risk that they progress and they never make it is very, very high. And that's why, we've transplanted a few patients. Those that get a transplant, I would say, have acceptable outcomes. I would say that we're not as excited as other programs. And we've been thinking really about, patients that have contralateral, arterial invasion, if we should be doing actually arterial resections instead of putting them to Mayo. And this is something that we could discuss, but we've been more aggressive in that regard, given, this big dropout rate. But I would say, and I think this is, pretty extended in the US, that if you're going to do transplant for perihyalar, your inclusion criteria should be Mayo. Patients should have neoadjuvant chemoradiation. Living donor is probably a very good option for these patients. I'll talk about that at the end of my talk. And, if you're doing transplants for these patients, the porta gets very, very messy, and you need to be ready to do jump grafts, both venous and arterial jump grafts. So I'm going to move again to a different kind of tumor, which is intrahepatic cholangiocarcinoma. We talk about perihyalar, which is a tumor that grows in the bifurcation of the bile ducts. These are mass-forming, peripheral tumors that grow in peripheral bile ducts. And if you're interested, I would recommend that you look at these guidelines. So these were the European Association of the Study of the Liver and the International Liver Cancer Association guidelines that we wrote now a year ago, and it has a nice summary of the management of intrahepatic cholangiocarcinoma. Just for, especially for the younger surgeons in the room, the treatment of choice of intrahepatic cholangiocarcinoma is surgical resection, period. That's what you're going to try and do on these patients. And usually what you do is a hepatectomy with a port lymphadenectomy. However, there's patients that are actually not resectable, and we're starting to think into protocols which patients may be a candidate for transplant if resection is not an option. And it's important to differentiate two types of populations. I'm going to talk first about, patients that are cirrhotics, that are undergoing surveillance and for, liver masses and develop a tumor that doesn't look like hepatocellular carcinoma. So we did quite a bit of research in the past, and this is even another spin. These were patients that were transplanted to what was thought to be hepatocellular carcinoma and were found to have intrahepatic cholangiocarcinoma in the explant, so biliary tumors in the explant. And that was always a contraindication, but we learned that very early tumors, and we described very early the same way as we described very early in hepatocellular carcinoma, single tumors less than 2 centimeters, actually could do very well with the transplant. The 5-year outcome over 70%, and the recurrence rate was very low. So we started to think, some of these patients were just excluding them for transplant, and they are going to do very, very well. And other programs have done the same thing. This is Paul Bruce in France, a large hepatobiliary program in France. They looked at similar outcomes, and they challenged, our data, which was very good, thinking, well, maybe the limit is not 2 centimeters. Maybe the very early is up to 5 centimeters. And again, going back to my point about HCC, probably the answer is not size and number, and we need better things, and I'll tell you what we're doing. But more data suggesting that very early tumors in cirrhotics can do very well with transplant. Finally, this is a relatively recent study from the U.S. National Cancer Database, with all the bias that these databases have, but again, showing that single tumors less than 3 centimeters had very good outcomes with transplant and better than surgical resection. Again, lots of bias in these kind of studies, but I think kind of proving the same concept. And these have made it to guidelines now. So these are the American Association of the Study of the Liver, ASALD guidelines for PSC and cholangiocarcinoma that now suggest that if you have a small tumor in a cirrhotic patient, you should be referred to a transplant center. And as I said, the International Liver Cancer Association guidelines have kind of the same concept. So the other population is, the patients that we see with completely healthy liver, large mass-forming tumors, multifocal disease. So I wanted to show you this trial that was started at Methodist in Houston plus MD Anderson. They have a very good, MD Anderson doesn't do transplants, but obviously have a massive enterprise in surgical oncology. Methodist, they do the transplants in Methodist. So they decided this protocol where patients with non-resectable intrahepatic cholangiocarcinoma that are treated with neoadjuvant for at least 6 months and had good response could undergo a transplant. They presented this paper many years ago with 6 patients, but more recently they presented this paper now, I guess 3 years ago, with a larger cohort. This by no means is randomized data, so obviously take the data with a little bit of caution because obviously there's a huge selection bias. But 65 patients included ended up transplanting 18. I think by the time, currently they're probably transplanted now around 30 patients. And again, non-randomized data, but the outcomes of patients that got a transplant was 57% at 5 years, with a high recurrence rate, 52%. And those that didn't get a transplant obviously had worse outcome with all the selection bias that there is in the study. So this study just tells us that there may be a population of patients that could do well on the transplant, and I think we need more research in these regards. We have a protocol and a trial in Toronto where we do similar things. Patients have to have a biopsy-proven cholangio, no limitation in size and number. They have to be at least 6 months on chemo, and they get a living donor. And this is a very similar trial that's happening in Oslo with a very similar inclusion criteria. Now, again, going back to size and number is not going to be the answer. So we wrote this review a couple of years ago, or one of my PhD students, on the use of ctDNA in this setting, which I think is very interesting. And we've actually done some research with Natera already. This is not transplant, this is resection. But this is one of the first studies that actually shows, detection of ctDNA in resectable tumors before surgery, and then, identifying some potentially favorable and targetable mutations in some of the ctDNA work. Again, very preliminary, small numbers, but I think a little bit where we're seeing this happening. I co-lead biliary with one of my medical oncologists, a big biliary registry where we're now sequencing and doing, PDOs, PDXs with every cholangiocarcinoma that we see in the clinic. And this is obviously a huge potential for, research and to determine which patients may be good candidates for transplant. So finally, I'm going to talk about even a more controversial topic, which is gaining a lot of attention in the surgical oncology and transplant world, which is liver transplantation for unresectable colorectal liver metastasis. And I thought I would start by showing you, the population of patients. Let me see if I can put this video on. No. Okay. All right. I guess I can show you the video. All right. Unfortunate. If I go back, let me try again. Sorry. Okay. So just, you won't be able to see the response, so you'll have to trust me. So this was a 37-year-old patient, with a sigmoid cancer, KRAS wild type, BRAF wild type, MSS. As you can see in the left, I think clearly unresectable and probably ever resectable colorectal liver metastasis, very high CEA. Patient started on FOLFIRINOX and panitumumab. The patient actually had an hepatic artery infusion pump in another center, and 20 months later, and I can show you the scan, the response was amazing. Lots of ghost metastases, almost everything gone. What do we do now? Oh, I can show you the scan. There we go. Okay, so that's the scan. So look at the difference, incredible response. What do we do? So, we know that the outcomes of patients with colorectal liver metastases, we know 50% develop liver mets, surgical resection. The combination of surgical resection and chemotherapy is the only chance for cure, but only a minority are going to be surgical candidates. And as you know, we can achieve relatively good survivals if we're able to resect all the disease with the combination of chemo. I like this framework that I guess Tom Aloya, when he was still practicing, did, which is, all the different things we can do with bilateral colorectal liver metastases, parenchymal sparing hepatectomies. In Europe, we call this Swiss cheese technique, where you do holes in the liver. You can do different stage hepatectomies. And I wanted to think about this population where, surgery is not an option. Some people would combine surgery and ablation, hepatic artery infusion. This is the population of patients that transplant may be an option. And I want to be clear, today, liver transplant is for patients that have unresectable disease. This is not for resectable disease, for patients that are clearly unresectable. So the best data we had so far was the data from Oslo. In Oslo, they had a very good problem that they had more patients, more donors than patients in the waiting list. So they started saying, well, we have this patient with colorectal liver mets, we can resect, why don't we resect the whole liver and do a transplant? And they started this trial, the SECA-1 trial, which showed, very interesting outcomes. However, every patient recurred post-transplant. I think what was important about this trial is that they did, develop the Oslo score and showed that some of the risk factors for recurrence was a large tumor, a high CA if they're progressing on chemo, and if the time interval between the initial diagnosis of, synchronous disease and transplant was less than 2 years. More recently, and this is now, just published in JAMA Surgery at the end of last year, again, disease-free survival is still, not great. So most patients would recur, but less than 20% won't, and a long period of observation. However, again, look at the number of patients at risk, but the 5-year outcome is pretty good in all comers. I think this is even better if you look at patients that have a low Oslo score, so Oslo score of 0 or 2, they actually can achieve an amazing 10-year outcome of almost 50%. And again, think about the alternative for these patients. Lots of active trials, and I won't go through this. There's even more at this point, and I'm going to show you the most interesting data in the next couple of slides. We started a trial now, probably like 6 or 7 years in Toronto, where patients that have primary in situ with synchronous liver mets, we start them on chemo as a first treatment. That's the standard of care. If they're responding for 3 months, then we consider resecting their primary. Sometimes they come with their primary resected. We assess them. We do all their transplant assessment. We're only doing living donors. We do expiratory laparotomy a week before the transplant and sample portal nodes. And then we do a living donor. By that time, they're always, they keep on systemic until 4 to 6 weeks before the transplant. There's a main inclusion-exclusion criteria. So up to 68, they have to be non-resectable. We have 3 surgeons looking at the scans, and then we actually send the scans outside to 2 outside of the institution surgeons to determine that this is unresectable. They need to be responding for at least 6 months, and they have to have a potential living donor. We're only doing living donors. And this is the main exclusion criteria. If they have a VRA V6 mutation and basically disease outside of the liver progression on chemo. We published our first interaction in JACS last year. I'm not going to go through all this, but just to tell you that this is a big funnel where we see a lot of patients. We've probably now seen around 150 patients, and the number of patients you end up transplanting is pretty low. And this is so the hepatologists don't get scared. This is not going to destroy your waiting list. The number of patients actually are low. You can still do your MASL and your PSC patients, no problem. So what have we done so far? I'm not going to show you all this. We've transplanted 14 patients. We're doing our number 15 next week. We've done a bunch of patients that had a pump, which is an interesting concept. Most of these patients were Oslo 0 or 2. 2 patients passed, 1 with recurrent disease, 1 without recurrent disease. And we have 4 patients actually with recurrent disease, some of which we're treating with surgery, and some of these recurrences are mainly in the lungs and have been resected. The first iteration of data of living donation in this setting was published in JAMA Surgery some years ago, a study that we combined our data with Rochester, New York, and Cleveland Clinic, again, just to show a proof of principle that living donation in this setting can achieve very good outcomes for some of these patients. Now, everything now has changed because this was published and presented in ASCO in June. It was amazing, René Adams, hepatobiliary surgery from France, a room full of oncologists in ASCO. So this is the first randomized trial called the TransMed trial, where they randomize patients to either systemic plus transplant or systemic alone. And I think the outcomes are incredible. So this is their, intention to treat. So before listing, and as you can see, look at the difference: 57% for transplant, 13% for chemo alone. These are, again, intention to treat from the time of listing. But if you look at actually the per protocol analysis, 73% to 9% differences. So again, look at these curves. There was, a lot of discussion. This paper is going to be published in a very big, important journal very, very soon. And this, I think, is going to change completely the way we think about these patients. What happened to our patient? Well, we didn't think we could do resection because I always worry about missing metastases, and I think I was right. Like if you look at all that, there was almost no disease, but all those white spots that you couldn't see in the CT scan, they're all viable tumors. This patient is doing very well now, probably 40 months after transplant, and there was a lot of mets in the liver. So what are the challenges and future directions? Well, I was actually changing this slide yesterday. I usually have this, that the current approach was not generalizable before the TransMed trial. Maybe now with the TransMed trial, actually, this is now generalizable. Are we giving patients exception points? Are we only going to do living donors? Is there a population of resectable disease? If you have 15 metastases that you can resect, is that better? Would you go in, resect 15? Maybe there's another 15 that you're not seeing, and maybe transplant is better. Wishful thinking, I don't know if that's the right answer. And I think, again, better biomarkers. I participated in this ASTS-HPV recommendations white paper in Boston a year ago, I guess. The paper should be coming soon, but there was a lot of people and a lot of interest, lots of surgical oncologists, lots of transplant surgeons. It was very good, and hopefully the outcome of this will come out soon. As you know, here in the US, Shimul Shah, who's I think now the lead of the liver intestinal program, is working on giving exception points to these patients. I don't know how you guys are going to do it because he's planning to give, 20 minus 15. So I don't know how these patients are going to get a transplant and when. We have been doing it differently in Canada. Once we stop the chemo, we put the patients in the top of the list and we make sure they get transplanted within 4 to 8 weeks, because if not, I don't know how you manage the chemo with this situation, but that's up to discussion. So I'm just going to finish saying that, obviously this is all great. and transplant oncology is great. I guess the question is, how are we going to transplant these patients? And again, I think you guys have the same problem that we have in Canada. We have a 30% waitlist mortality, so organ shortage is still a problem. And when you think about transplantation for patients for cancer, you need to think about how many patients in the list and how many donors you have. We've usually thought about this concept that we should have a 50 to 60% 5-year survival for these patients. Now we're thinking more about 50%, 10-year survival. I really like this framework from Vincenzo Mazzaferro, where you need to think that when you transplant a patient for cancer, it's not only about the patient, right? It's also about the community, right? And your organ, your waiting list. So there's, clear indications that are very appropriate, and then there's some that are a waste. If you have a patient with an intrahepatic cholangiocarcinoma and lung metastasis, well, you're throwing an organ to the garbage. And as I said, organ, shortage is a problem. This is our own data in Toronto, where we have a, mortality rate in the waiting list of 25 to 30%. We were talking about this yesterday at dinner, but machine perfusion is going to change waitlist dynamics. This is our fellows with the Organox machine, which is the one we use, in the US. Now you guys have like a 1-800 number where you call for livers, and they just bring you a liver, ready to go in the morning. But this is definitely changing. The other thing we've done in Toronto very aggressively is a living donor liver transplant program. I know you guys have been doing the same, and Dr. Guadalupe has been very active among the rest of the team in developing or extending that. And we have done probably now around 1,700 living donors. Around 25 to 35% of the transplants we currently do, which are 240, are living donors, mainly right lobes. And when we see patients in clinic, we tell them you can go in a waiting list, but it's way better for you if you get a living donor and you have a living donor. We really encourage that. And if you think about this, framework again, and you include living donors here, well, this negative gain for the community really disappears, right? Because a living donor is actually taking a patient out of the list and giving an organ to the list. So really, the 5-year minimal recipient survival with a living donor is an ethical question more than a location question. And if you ask a patient, if a patient comes to clinic with 3 siblings, and you ask them, what would you like the 5-year outcome of your sibling to be? They say 10%, 20%, whatever. And obviously, we're doctors and that's not what we should do, but it's really an ethical question, and it becomes more cumbersome. When Nico was a fellow with us, we published this paper in Journal of Hepatology actually demonstrating that for hepatocellular carcinoma, if you have a potential living donor, well, your outcomes are better for intention to treat. This is not rocket science. Your dropout risk disappears, and actually post-transplant the outcomes are the same. But if you think from the time of listing, it has a ratio of 0.75, you have a 25% less risk of dying if you have a living donor. What are the advantages of living donation in this setting? As I said, you decrease your dropout rates. We're getting lots of not great livers that come from deceased organs, so living donors are a really healthy, perfect graft. And it's an unlimited source of grafts. You can talk about extended criteria. This is a very controversial thing I'm writing there, but should we be doing palliative transplants to patients that we know are going to recur but live 10 years? Well, maybe. And it adds another organ to the system. So I would like to summarize, saying that, the selection criteria for patients with hepatocellular carcinoma, I think should avoid size and number criteria only, and I think we're moving already beyond that. I think liver transplant for perihepatic cholangiocarcinoma is an accepted indication for liver transplantation. Liver transplant for patients with intrahepatic cholangiocarcinoma, it's a viable option in selected cases, but I think we need more research. And we now know that liver transplantation is a better treatment option than systemic chemotherapy for patients with unresectable liver metastasis in a randomized controlled trial. I thought I would finish thinking, of how things have evolved and some of the challenges I think we're going to face. So I think in many transplant programs, transplant oncology is the main indication for transplant, and this is only going to grow. I am certainly biased, but I think it's, we'll see in the next years. And I think it's likely, to keep evolving as we keep learning about selection, which patients are going to do well or not. And I think the evolution of multidisciplinary teams is critical. It's been improving, and I think the involvement of oncologists is really important. I've been lucky enough to give now talks at GI ASCO. I've been involved in committees, and I think that's the way the oncologists are going to get engaged in this. Several challenges. I think the way we're going to integrate new systemic therapies, local regional therapies, how are we going to sequence this? Lots of food for thought and lots of opportunities for research. I think we need better patient selection tools. I think, alpha-fetoprotein is not the answer. We need better. There's a lot of unserved areas with a huge potential. We're hosting a big transplant oncology symposium in Chengdu in China in December, try and bring some of these things together, huge potential. And I think the separation of surgical and transplant oncology needs to, get closer and closer, because I think that's the way we're going to evolve in this field. So with this, I really want to thank, everyone for being here, and thanks the organizers. This is my research team in Toronto, which I thank them for all the work, and I'm happy to answer any questions. Thank you.
Gonzalo, that was an excellent talk. I think we all agree that, in people that work with cancer, biology is king and sort of selection is queen. My question is related to transfer HCC. Past 20 years, always thought like, well, you're only using size and number. We're always looking at, what expanded criteria. Now we're acting, other biomarkers like alpha-fetoprotein. To me, that's still very rudimentary. I think one of the exciting things that's happening in cancer is learning more about the sort of genetic and molecular markers. I think one of the difficulties with HCC is that most patients don't get biopsies anymore because we're using, LIRAS. Do you see that as a problem? I mean, you mentioned a little bit about sort of like liquid biopsies, but to me, that may not be the same as actually getting the biopsy initially, before treatment and trying to figure out, okay, what is the biological, significance, and what's the prognosis for these patients?
Yeah, I think that's an excellent question. So I'm, Jordi Bruce, who's one of the leaders of HCC. Hopefully he's not listening to me, but he was very critical in doing biopsies to these patients, and that, at the time is what it was. But I think now we need to biopsy. In Toronto, actually, we have a protocol, because it's at this time it's research, right? Like the standard of care is not biopsy, but we're trying to biopsy every HCC, and we're trying to sequence every HCC for exactly that reason, to learn. So I think we're very behind, and I agree entirely with your point. Like, we're doing some work with Natera, and the problem is that it's very hard to identify the tumor mutations in the blood. We're not there yet.
Yeah.
So I agree. I think the field needs to move to biopsying way more liver cancers, and it's already moving there, right? Like the oncologists now, to treat with IO, they get biopsies, we have more tissue, and there's more data coming out now. HCC is very different than cholangio. Like I don't think we're not going to have targetable mutations the way we have in cholangio, but yes, we're going to learn about cancer evolution, which patients, et cetera, which mutations are favorable, et cetera. So I agree entirely.
Yeah, I'm Charlie Front, I'm colorectal surgeon, so I'm particularly interested in the colorectal mets. So I still don't quite understand the TransMet trial. I guess I go back and read it. So what are we talking about now? I mean, your selection criteria, I think you said you had evaluated 85 patients, only 7 got to transplant, and I suspect a lot of people are flying to you. So that's a very small number of people that qualify, and then you then implied that Adam just sounds like we're going to transplant everybody with metastatic disease. So where are we headed with that, do you think? And how is it going to transform this?
Yeah, so I think that's a great point. So what I would say is that from a colorectal surgery perspective, I entirely agree. Like if you look at the whole population, this is a problem for 1 to 2% of patients. So just to be clear. Now, I think there are that 1% at a population level. There's a lot of patients that you see with sigmoid cancer and 30 metastases in the liver that are stable on chemo, for 6 months. And then we start thinking, well, and they're young, they're transplantable otherwise. And then we start thinking, well, the primary doesn't need to be taken out because they don't have symptoms and you wouldn't do it for a standard of care. But you say, well, maybe we should start considering resecting some of those tumors in combination with your transplant surgeon, saying, well, we're going to do a sigmoidectomy. And then let's see what happens 6 months after. Because if that patient then 18 months after the primary diagnosis still has, missing metastasis in the liver, 30 spots that you can't see, those are the patients that may be candidates for this. Now, where it gets very tricky, and I discussed with my surgical oncology colleagues, I work with Sami Chadi, a colorectal surgeon up in Toronto, is to convince to resect the tumor, the colon cancer, which, in general, you wouldn't do. The only reason you would do it is to qualify for this, these protocols. So just to answer your question, where do I see it? I see it for that population of patients that had good response for chemo for a prolonged period of time and have clearly non-resectable liver disease. And probably don't need a massive colon resection. I've been I've been seeing patients that need a pelvic exam, and I've said, listen, we shouldn't be doing this. Like, this is too much. Now, if the patient needs, a sigmoidectomy that you can do, and the patient goes home in 48 hours, I think it's reasonable.
And you kind of already kind of answered my next question, I think, is how are you guys addressing the primary and the timing? Do you sounds like you do chemo first, then resect, then more chemo, or you're just taking the thing out front and then getting them 6 months in or whatever?
I don't think we should do that because, obviously, response to FOLFOX are very high, but still there's some patients that are not going to respond. So if I see a patient with synchronous disease today, I tell them to go on chemo. I go on chemo for 3 or 4 months until we see that they're responding. Then we tell them, listen, we could consider this. There's no rush, like time goes in your favor. Like all of the patients, both in the transplant and AIR trial, had their primary diagnosis like 2 years ago.
Great talk. I enjoyed that. Todd Bauer, surgical oncology. My question about your criteria for transplanting the colorectal mets, major vascular invasion is a contraindication. Do we understand what biologically about the tumors is different about those and why that would portend a poor prognosis?
Yeah, so I think that's an excellent question. So my short answer is no, or at least I don't. We're extrapolating. I mean, we've always tried, when we started doing this, we tried to, we're trying to be selective and have good outcomes. So we said, first of all, it's pretty rare for colorectal mets to have invasion of vessels, very rare. But if they do, there's something bad about them, or that's what we thought. So that was the only reason. Now that we have so much data, if I have a patient that, had a portal vein invasion 2 years ago and now it's gone and the metastases are responding great, I may consider it. But we wanted to be very cautious at the beginning to have good outcomes. But I think I actually don't know what confers the worst prognosis, and it's so rare too.
Any other questions? We're just about on time, but if there's one more question. If not, Gonzalo, if I can borrow the mic. Kurt Tribble and I exchanged an email earlier this week talking about the close relationship you have with people who you train with. So I appreciate Nico and Gonzalo getting together and helping to share this new process. Nico may have mentioned this is something that we're investing hard in at the University of Virginia. Zach Henry, our hepatologist, is sitting in the front row and paying attention, except for when I was distracting him. So thank you, everyone, for being here. Gonzalo, this is a small token of our appreciation.
Thank you so much.
Thank you for coming.
Thank you. Thanks so much.
Must be a medicine day.
I know.
Yeah, no problem.
It's
I want to make sure, like, when we have these panel speakers,
We're happy to come. So yeah, I'll, if you want to just email me, I can introduce you. Yeah.
I was thinking, like,
Yeah.
You're a straight line. We moved around just now.
oh, that's perfect.
You mean like whatever, like gene analysis, yeah, so that later we can maybe.
Okay. Anyone that
But he
was
was
even has
usually
has,
we probably could have.
it looked like a scientific time period in which they were.
There was a little bit of
internal
blood
testing, so way fine.
Yeah,
So a little bit better going up.
but are you banking it too? That's what I really want to do. I want to do that.
Now I know he doesn't have an intercom.
No league.
Generally, don't regret any of this washout.
Will you have any patients? I feel like I owe you some.
Yeah.
We opened, we looked.
Oh, just one.
Yeah.
You gotta go see some now, and then if there's anybody upstairs, sorry.
Yeah, you can.
Okay.
Cut it out.
Sung, we flipped 9:30.
Bernie,
We're gonna
Bernie's
go see
son.
Sung
Yeah.
now.
And then we'll-
Oh, that's
Then go back upstairs.
Thanks for your help.
I'll teach us through that.
Yeah, thanks so much. Thanks for having me.
Yeah, we're being.
Perfect.
Yeah, of course. Hey, yeah, of course. No, we, you know, yeah, well, it's like blending our service. Yeah. I'm really excited. Yeah, and it's not something, you know, like half the stuff that they're doing, we already do on them. Right.
You get tired of that talk, so you had to come to another talk. By the way, if no one's using this thing, then you can sleep on the floor. I now had the curtain the other day.
Really? Dang.
Oh, it's carpeted.
I bet it's peaceful back there.
Yeah, it is very, very peaceful. So I'm gonna wake up and it's gonna be like.
Oh my god. They have to like emerge from the back. Yeah.
Yeah, it's like a lot of basis to anything that do this. Then you realize no units. Knowledge, like, we're gonna like this bad of biology. I haven't got the answer, but actually, that's correct. Basis that I'm the bacteria. Yeah, that's why I'm. Oh, that was basic. 1 year people have to do. So I did have a sense of point. Stressed out. Yeah, I agree. But somehow, like, really go over time, it could be a little, like, for purposes for a line. Yeah, but still, it keeps moving, you know, like, well, once that, like, yeah,
Yes, but I don't want you to be